Yeah, live, sir, we can begin.
So, hello everyone. A very good afternoon to all of you. I am Dr. Vinay Prohit. I am a pharmaceutical physician and working as a DGM in Medical Affairs Department of Lupin Limited, one among top 5 research-based Indian pharmaceutical organizations. It gives me immense pleasure to extend to you a very warm welcome on behalf of entire Lupin team in this special Foxy Digital Initiative eSampark. This eSampark initiative is a series of 24 e-learning modules, and today is the chance of the module 3, which is going to be the management of post-bariatric surgery pregnancy. So for the same, we have blessings of Dr. Alpesh Gandhi, who doesn't need any introduction. And for today's session, we have Dr. Prakash K. Mehta as an esteemed speaker. Dr. Prakash K. Mehta is the Chief Division of Maternal Fetal Medicine and Head of the Department of Obs and Gynae, Bhagwan Mahavir Chand Hospital in Bengaluru. He is a postgraduate and post PG fellow teacher and examiner in metal fetal medicine and obs gynae. He is also an expert of medical legal aspects for the gynecology practice. He has numerous articles in various journals and contributed to chapters on metal fetal medicine in many books and delivered oration in the field of metal fetal medicine. He has served as the president of Society for Maternal Fetal Medicine, and in the past, he was president of Bangalore Society of Obstetric Gynecology and joint secretary of FOGSI. So, with this, we will start our scientific agenda. I would also request Dr. Alpesh Gandhi, who is the president of FOGSI, to give some opening remarks before Dr. Prakash Mehta goes ahead with the scientific topic.
Thank you,
Alpesh, sir,
Dr.
please
Vinay.
give your. Yeah.
Thank you, Dr. Vinay. I would not take much time. Very good afternoon to all of you. On behalf of Foxy, I extend warm welcome to dear Prakash Bhai and all the viewers and Team Lupin. It is said that India is a country of malnourishment or malnutrition, but at the same time, across the world, obesity is emerging problem, and we are also not spared from this problem. So today's topic is very interesting, and we can say a latest topic, something new: management of post-bariatric surgery pregnancy. In our routine practice, we are now frequently come across a cases of many cases of pregnancy with obesity, and not only that, India is also one of the leading country across the world having maximum number of pediatric surgery. So that is why we are not in next few years we all are coming across such type of patients who has undergone pediatric surgery. So what care should be taken during pregnancy, before pregnancy, and after pregnancy? We have an eminent speaker, a great orator, and a very good friend of mine, and a humble person, Dr. Prakash Mehta, with us. I am very eager to hear him, so I will not take much time. And with this, I hand over mic to Dr. Vinay.
Yeah. Good afternoon, everybody. We have a very dynamic Foxy president, Dr. Alpesh Gandhi, who has taken on himself to have this kind of e-learning and spread the knowledge all around, even in this very, very difficult times. It's not easy to arrange such programs. It requires a lot of coordination, a lot of availability of various people. Yet Dr. Alpesh has taken on himself to do this kind of work. And thank you, Dr. Alpesh, very much for trying to bring up knowledge of all of us across India and even maybe outside. Today's topic is going to be on a post-bariatric surgery pregnancy. Now, as Dr. Alpesh rightly pointed out, in India, we are all the time worried about malnutrition. We are worried about undernourishment. We are worried about poor weight gain and all that. So why are we going to talk on bariatric surgery and post-bariatric surgery pregnancy? That's because obesity is something that is a pandemic. You know, we can easily compare with our corona pandemic. It is that kind of a pandemic. The only thing is obesity is spreading silently and slowly all across the world. And we have already heard that we are the highest bariatric surgery performers in the entire world. And most of these patients who undergo bariatric surgery are young women or sometimes even adolescents. It's been done for severe PCOS, uncontrolled diabetes, and whatnot. So, a post-bariatric surgery pregnancy is something that all of us are definitely going to come across. If you have already not come across now, in the next few months, next few years, even in a small town, even in maybe even in a village, we are going to have a post-bariatric surgery pregnancy. Hence, we should know are we expecting any extra problems and what we are supposed to be doing. Now, in the evolution of human being, we know that we started, with the apes and then the Neanderthals, and finally the human being evolved, and then finally we found that we had the obesity, and now after bariatric surgery, we have a further evolution where a fat person becomes thin. Now, as I told you, there is a dramatic increase in the obesity worldwide. 13% of the population is characterized as obese by WHO. This is the 2018 statistics. Now, maybe even it is more. Bariatric surgery is increasingly utilized and is an effective approach for a sustainable weight loss. Now, why are we talking in terms of bariatric surgery? Why not any other things? Yes, a lifestyle modification is important. Maybe some medications are also important. But bariatric surgery is something that comes in with a lot of advantages. Now, the first point would be, as a person, as an individual, it brings down the morbidities. We know that severe obesity is associated with diabetes mellitus, it is associated with hyperlipidemia, hypertension, and more important, obstructive sleep apnea. Now, let me remind you here that obstructive sleep apnea is something that a lot of work is going on for its relationship with preeclampsia now. So, sleep apnea is not that is something, you will find only in a middle-aged person or an elderly person or that kind of a picture. So, it is seen even in younger women. Bariatric surgery tends to bring down the incidence of all this. And we definitely know by now, with all the statistics that we have collected, that diet and exercise or pharmacotherapy, while having their own place, are not as effective as bariatric surgery. People can diet for some time, can exercise for some time, but at the end of a few months, maybe a year, maybe 2 years also, then they tend to give it up. So those who are morbidly obese will have to perforce undergo a bariatric surgery. And the most important thing for us as interested as OBGYNs is that it improves fertility in the obese women. Now, there are the very, very important points: decreased complications, decreased stillbirths, decreased incidence of diabetes, preeclampsia, thromboembolism, and maternal death naturally. There are articles which are claiming that there is a decreased risk of fetal malformations. And with obesity, we have possibly an increase in congenital heart defects and the orofacial clefts. So once the obesity goes away, these defects might possibly come down. Also, there is a decreased chance of postpartum hemorrhage and poor wound healing associated with obesity. All of you, those who have handled very obese women, will immediately agree with me that to do an LSCS on an obese woman and to deal with a postpartum hemorrhage, because the amount of drugs you give may not be sufficient because of so much of distribution of the fat. So once we do a bariatric surgery, possibly all these complications can come down. Now, the next question that comes in is, how soon can the woman become pregnant after surgery? In my pre-pregnancy counseling clinic, I quite often get patients who have just finished 3 months, 4 months into bariatric surgery, and then they come and ask me, "Doctor, when can I get pregnant?" Or there are some who already have managed to get pregnant and now come to me with worries that what's going to happen. My bariatric surgeon told me that for the next 1 or 2 years, I should not get pregnant. Doctor, it's only 4 months and I'm pregnant now. Now what happens? Now, please remember that most of these women who undergo bariatric surgery and come with pregnancy have already gone through quite a bit of infertility treatment. They may be possibly infertile for 8 years, 10 years. My last bariatric surgery patient was infertile for 15 years. Now, a patient who has been infertile for 15 years, sometimes, they don't have that kind of patience to wait for 1 or 2 years before getting pregnant. So the basic teaching is avoid conception for 12 to 18 months after bariatric surgery. Now, why do we have to wait for this period? Because we have to optimize weight loss. We all know that pregnancy in the postpartum period, there might be some increase in the weight. So to optimize this weight loss, and one other important thing is, after undergoing a bariatric surgery, the patient quite often is in a state of ketosis and in a state of very many nutritional deficiencies. So we do not want these nutritional deficiencies and the ketosis to be present at the time the woman gets pregnant. Post-surgery period is also characterized by a catabolic state because there is less anabolism, more catabolism to bring down the total metabolic rate. Over a period of time, over 6 months, 12 months, 18 months, some people claim 24 months, there is a stabilization of the nutritional status. And another very important thing we need to remember is an antepartum ketosis can affect a child's intelligence. See, we are not talking about a structural malformation. We are talking about the functional teratogenicity which could be there. Now, having said this, supposing a woman comes to me post-bariatric surgery after 4 months or 5 months, do I tell her, no lady, your pregnancy cannot be continued, you have to undergo MTP? The answer is a big no. Why we would want an absolutely stable condition before a pregnancy comes in? Let us say by accident or by chance a pregnancy has come in. There is no evidence to support that early pregnancy is harmful. There is a beautiful article by Yar MM and all in the Obstet Surgical of 2013 where it is beautifully analyzed that if a woman gets pregnant, let her be, support her. Don't do a termination of pregnancy. Now, just a few days back, a 30-year-old lady presented for the first prenatal appointment. It was a prenatal appointment. She has a bariatric surgery. She has undergone a bariatric surgery. Now, I have to counsel her. What information is needed for proper counseling? So, before counseling a patient, we need to know what type of bariatric surgery she has undergone. Because each type of bariatric surgery comes in with its own problems. Like, when you say bariatric procedures, there are various types. They could be, the first type is what we call as a restrictive surgery. What do you mean by restrictive? You bring down the capacity of the stomach so that the person eats less and becomes thin. So there are various types of restrictive surgery. The first one, the older one, is vertical banded gastroplasty, which is generally not done often now. The second one, which is very commonly done in the Western countries, even in our country it has been started, is the laparoscopy adjustable gastric band. Now, here there is a band. If you could see here, now there is a band put around the stomach so that you have a smaller upper chamber and a larger lower chamber. And there is a band here which can, and there is an access port here, so this band can be inflated and the amount of food entering the lower chamber can be restricted. Now, this type of surgery is very good for pregnancy. Why is it good for pregnancy? Because I can adjust the band size so that in pregnancy I can allow a little more food to enter into the lower part of the stomach. But the drawback is, in this world we don't get anything without a drawback. The drawback is the inferior weight loss. The weight loss is little slow and over a prolonged period. The next common surgery that we do is what is called as a sleeve gastrectomy. That is, what is done is along the greater curvature, a sleeve of the stomach is removed so that ultimately stomach remains very small. The second important type of bariatric surgery is malabsorptive. Now, in malabsorptive surgery, we have the older surgery, which is the jejunal-ileal bypass, which is not done very often now. The second little more commonly done is the biliopancreatic diversion. And the third one is biliopancreatic diversion with duodenal switch. I don't think we really need to go into the technicality of it, but we need to know that there are these kind of surgeries because each surgery will come its own effect during pregnancy. And the last one, which is a reasonably common as compared not as common as a sleeve or a band, but reasonably common, and that is a combination of a restrictive and a malabsorptive type. Now, when we say malabsorptive, we mean that the intestines are not allowed to get exposed to the nutrients, so that the amount of nutrients absorbed are lesser. That is why the patient loses weight. Whereas we saw in the gastric sleeve or the band that it was a restrictive type of surgery, so that little amount of food enters the stomach. Now you have a Roux-en-Y gastric bypass, which is both restrictive and malabsorptive. So we need to know which type of surgery the woman has undergone. Now, just to bring a common outcome of it, in a restrictive surgery, iron deficiencies are more common, folate deficiencies are common, B12 generally is normal, vitamin D remains normal, calcium remains normal, hemoglobin there might be a small drop, albumin is normal. But in a malabsorptive kind of bariatric surgery, iron, folic acid, B12, D, calcium, hemoglobin all come down, and added on to that we get hypoalbuminemia also. Now, as obstetricians, whenever a patient comes to us in 7th month with a pedal edema, only two things come into our mind: the physiological edema or the edema of preeclampsia. But please remember, in a patient who has undergone a bariatric surgery, you need to remember that there could be hypoalbuminemia causing this kind of edema. Now, the next question is, really a pre-pregnancy care is required? Why can't I finish everything when I'm doing the bariatric surgery? That counseling can take care of everything. Now, pre-pregnancy counseling is important because the woman needs to know what she has to do once she tries to attempt a pregnancy. The first and the foremost, I already told you, is to wait for 18 months after surgery. She has to take extra vitamins and the minerals in the pre-pregnancy period, not after getting periods, before getting pregnancy, so that she starts pregnancy without any deficiency. She needs to know that she may require a cesarean section during this delivery. The chances of vaginal delivery are not absent, but they are definitely lesser than for a normal patient. So we need to warn that to the patient, and she needs to undergo regular blood tests to identify what kind of a nutritional deficiency she is having. Now, are there any special recommendations regarding dietary behavior both before pregnancy and during pregnancy? Yes, there has to be a regular eating pattern. She needs to have 3 small balanced meals. Snacks can be included between the meals if the patient feels hungry. And you know, all our pregnant patients feel extra hungry. And but the snacks have to be appropriate in size and texture and help to achieve a balanced intake. Now, during pregnancy, we know that the taste changes occur. We know the pica of pregnancy is always there. So the patient should be taught how to experiment with different foods to overcome these taste changes. Now, we also need to tell them that the consumption of the solids and the consumption of the liquids have to be different. Do not give solids and liquids to result in either a dumping syndrome or a vomiting in these patients. Patients should learn to take small bites, eating when full. If she's eating a pizza and she has one piece of pizza and she loves it, no. If she's feeling full, stop at that one piece. Do not go further. Now, food hygiene is equally important, because the moment you tell them to have healthy food, sometimes they forget about the food hygiene. So we have to reiterate the food safety advice to avoid complications like gastroenteritis and toxicity. That means we need to ask her to have more of home food and less of outside food. Although I'll give you an example of pizza, that pizza may jolly well be prepared at home. Avoid non-pasteurized dairy products. Avoid fishes like shark, marlin and swordfish because they have a very high mercury content. Liver and products such as paste and cod liver oil to avoid consumption of too much of retinol-based vitamin A. We know that retinol-based vitamin A is embryotoxic. So we should ask them to avoid these products which have a very high level of vitamin A. and they have to avoid eggs unless they are salmonella safe, because salmonella comes very easily during pregnancy. So they have to be salmonella raw egg. Now, what nutritional deficiencies are obstacle patients at risk for after bariatric surgery? Are there any special considerations for nutrient replacements? Let us try to answer this question now. Now, nutritional deficiencies, in spite of whatever you do in the pre-pregnancy period, you have a wonderful patient who has followed all your advice, got pregnant after 18 months, has had all food, everything is hunky-dory. Still, 20% of them are going to have nutritional deficiency. So we should look for it in every bariatric surgery, post-bariatric surgery patient. Now, in the patient who has undergone a RYGB type of a bariatric surgery, that is Ru and Y I told you, and the vomiting is always present, and that could increase the deficiency. The common deficiencies that occur during pregnancy could be protein, iron, vitamin B12, folate, calcium, all the fat-soluble vitamins including A, D, E, K, and thiamine. Is altered after a bariatric surgery, and the surface area of absorption decreases. Hence, there has to be changes in the preparation of the route or dose. So we just can't blindly give whatever nutraceutical we want. We have to keep this point in mind. Liquid or chewable vitamins are better absorbed than tablets. Calcium carbonate depends on acid for absorption, but not calcium citrate. So what would be the logical thing? Do not give calcium carbonate in pregnancy, but replace it by calcium citrate so it could be absorbed. Absorption of vitamin B12 depends on intrinsic factor, which will obviously be altered, especially in a surgery like when you have done a gastric sleeve. Hence, vitamin deficiency of B12 may not be corrected by oral supplements, because there is no intrinsic factor to allow it to absorb whatever oral supplements you are giving. So IM injections may be required. Now, if you are not talking of nutraceutical, but you are talking of other drugs, please remember that there will be a reduced drug absorption, whether it could be let us say a drug like oral antibiotic, or it would be less absorbed, and hence periodic monitoring is required. So, I mean, this is a big chart, I'm sure, bariatric surgery pregnancy patient as compared to a pregnancy period. Now, the two important things are calcium citrate, vitamin D, and iron. We'll go a little bit more detail about it. The rest I'll quickly run through. Calcium citrate and vitamin D, we know in pregnancy 1000 milligram of calcium and 400 international unit of vitamin D is required. But for our patient who is post-bariatric surgery, 2000 milligram of calcium and 800 international unit of vitamin D is required. That we have to keep in mind. As far as iron is concerned, in a normal pregnancy, generally 34 milligram of elemental iron should be enough. For a post-bariatric patient, 45 to 60 milligram of elemental iron is required. Same thing further, vitamin B12. I already told you we have to give IM injection. So a 1000 microgram or 1 milligram injection can be given every week. Thiamine is increased. Folic acid, we have to give 5 milligram. Why we have to give more folic acid? We will go to it in the next few slides. Vitamin A, we do not replace in a normal pregnancy because of its embryotoxicity. But for a post-bariatric surgery patient, vitamin A is required in the dose of 5000 international unit per day. What is important is do not give retinol type of vitamin A, but give beta-carotenoid type of vitamin A. Zinc, not much difference. Magnesium, not much difference. Iodine, a mild increase in the requirement. Now the energy requirements are more. Now, why are we going in so much of detail of all this? Because a bariatric surgery patient has undergone a bariatric surgery just to lose weight. Now, pregnancy and post-pregnancy, a few kgs of weight is anyway going to be added. So, we do a balancing act. We want her to gain weight enough for fetal support, but we do not want her to gain so much weight that it becomes difficult to lose after pregnancy. So, that balancing act has to be done. Now 200 kilocalories per day increase is required, but that is only in the final 3 months. Now, what is more important is the patient has got certain expectations of weight before, during and after surgery. So our counseling is very important to give her realistic expectations of everything. What would be her weight before pregnancy, how much weight she should gain during this pregnancy, and after pregnancy, what is going to be happening. We know that patients are worried about weight gain during and after surgery. Today, every alternate patient who comes to my OP, although they are high-risk pregnancy patients, still are worried about the weight gain. Now, imagine a patient who has undergone a bariatric surgery, they'll be even more worried. And you know what, the patient may not tell you, but this may act as a detriment, as a barrier for her to have a balanced diet, because she may feel her weight will increase. So we need to clear these doubts. Now, at the other spectrum, even a post-bariatric surgery patient, like any of our normal patients, which we quite often see in our outpatients, is that they have a misconception that they have to eat for two. The nanny or the dadi at home tells, oh, beta, you are two now, you have to eat for two. So they keep on eating for two and suffer excess weight regain. Okay, in a bariatric surgery patient is a weight regain. Avoid any further loss during pregnancy. See, some of the patients, you have all kinds of patients. Some of the patients are so tuned mentally that they want to avoid, they want to have weight loss even during pregnancy. So please explain to them and avoid this further weight loss during pregnancy and focus on a balanced variety of dietary intake. Protein deficiency is a little uncommon, but can occur because of intolerance of protein-rich foods in this patient during pregnancy, and of course the malabsorption procedures can result in it. We already discussed that the hypoalbuminemia can present with edema, which could be confused as a normal symptom or preeclampsia. So we have to give at least 60 milligrams of protein per day, but please remember it has to be tailored to the individual patient. We cannot tell them to have, what is the textbook diet prescription. You need to sit with her, talk with her, maybe put across her to your dietitian who is used to a post-bariatric surgery patient and ask them to give a proper protein diet. Micronutrients, deficiency of micronutrients are very common. Why they are common during pregnancy? Because pregnancy-related symptoms do not allow certain kind of diet to be taken, and there is an increased both maternal and fetal demand. Now, one point here I would like to say is copper deficiency. I'm sure none of us would ever think of a copper deficiency when there is anemia present in any of our pregnant patients. But in a patient who has undergone bariatric surgery, if she has got a non-responding anemia, apart from hemoglobinopathies, apart from thalassemias, think of copper deficiency. Do a copper estimation in the serum and think of copper deficiency, because copper deficiency in these patients is not as uncommon as you would find in a normal pregnant patient. Iron deficiency is most commonly encountered, as I already told you, more common after a Roux-en-Y gastric bypass or biliopancreatic diversion surgeries. We all know that iron supplements have gastrointestinal side effects, and they may exacerbate, the post-bariatric surgery patients have already gastrointestinal side effects. They feel full, they feel bloated, they feel heavy, all kinds of things they have, vomiting, nausea, everything is there. So for them, when you give iron supplements, exacerbation of the pre-existing symptoms occurs, making compliance with the supplements very difficult. Patient will tell you, "Haan, Doctor Saab, maine liya hai," but she would have never taken it. Weight loss after bariatric surgery results in falling serum hepcidin levels, and falling serum hepcidin levels potentially improves iron status. So there is a silver lining to this dark cloud, that although the patient may not be able to take orally well, remember that because hepcidin levels have come down, her iron status improves. Now, generally they require 45 to 60 milligram of elemental iron with vitamin C, or give them IV iron and they would be fine. Calcium and vitamin D, I already told you, they require large doses, especially after a gastric bypass, gastric sleeve, or a duodenal switch procedures, because the absorption is reduced. 800 international units of vitamin per day is what is recommended. Folic acid deficiency. I told you before that when we talk of congenital anomalies, I will be coming back to it. So folic acid deficiency is present because of the low gastric pH and the reduced capacity for intestinal absorption after a bariatric surgery. So in the bargain, what happens when there is a folic acid deficiency? We all know that NTD or the neural tube defects are more common when there is a folic acid deficiency. So these patients are potentially more prone for a folic acid deficiency as compared to your normal pregnant patients. Hence, 5 milligram of folic acid daily should be given pre-conception and definitely for the first 12 weeks of the pregnancy. Vitamin B12 deficiency we already discussed because of malabsorption and decreased intrinsic factor. They need 1 milligram of injection of hydroxycobalamin. Vitamin A supplementation, I'm telling you this repeatedly, is generally avoided in pregnancy because of risk of fetal malformation. But this fetal malformation comes due to retinol isoforms. So we do not give retinol isoforms in these patients, but we give beta carotene forms. Now, what happens if we do not supplement vitamin A to these patients? They can cause night blindness, increase maternal mortality, and have an increased preterm birth. So please supplement vitamin A, a safe kind of vitamin A, in a limited dose in these patients. Now, how should she be followed throughout the pregnancy? Number 1, I already told you detailed history in the first prenatal visit. If she has not come to the pre-pregnancy time, in the first antenatal visit, take a detailed history. Unique nutritional deficiencies, I already given an example of copper deficiency, not routinely considered in normal OB patients. Please keep your eyes open for them. And patients can complain of persistent muscle pain, cramps, bruisability, skin, mucosal changes. We generally tend to brush them off. Arey hota hai, ye sab to pregnancy mein hota hai. No, when a post-bariatric surgery comes with this kind of complaint, please look for symptoms of micronutrient deficiency and you may save her a lot of tears later. Now, during the first prenatal visit, we need to do a complete blood count. We have to do a ferritin, iron, vitamin B12, thiamine, folate, calcium, and vitamin D. Identified deficiency should be corrected and monitored with monthly assessments. Further surveillance. You do that every trimester is of blood count, iron, ferritin, vitamin B12, calcium and vitamin D. All these are done every trimester to ensure that you do not miss out on any problem. Now let's come to the early obstetric problems. Miscarriage, non-surgical weight loss may reduce the risk of miscarriage. However, the impact of bariatric surgeries on miscarriage rate have not consistently shown a benefit. That means my patient post-bariatric surgery is going to have the same risk of miscarriage as possibly the obese patient has. Nausea and vomiting are very, very common in these patients. They have to be asked to eat little and often, increased intake of nutritional fluids, not nutritional solids. They have to take antiemetics prior to the onset of nausea. If they are believers in some kind of herbal remedies, ginger is a very good complementary therapy. Avoid foods that induce nausea. Do not allow her to be in the kitchen or allow her to smell that strong smells that is very common with our Indian cooking. And ask her to take a short walk before meal so that the stomach gets emptied and this kind of vomiting will not come. Should patients be screened for gestational diabetes and how should they be screened? This is a very important feature. Although there is a lower prevalence of GDM among women who have had bariatric surgery than among obese women who have not undergone this surgery, yet the incidence of GDM in this post-bariatric surgery patient is definitely higher than a general obstetric population. That means we are better off than a very, very fat patient, but we are not better off than a normal pregnant patient. Now also remember that after a gastric bypass, while the fasting blood glucose can be normal, there is an altered pattern of postprandial glucose dynamics. Now why as an obstetrician we should know? We should know it because our blood sugar tests will be altered and we need to know this to interpret our blood sugar tests. Now women with a history of type 2 diabetes prior to bariatric surgery become euglycemic. That's one of the advantages of bariatric surgery. And may also remain euglycemic during pregnancy. We know that pregnancy-related insulin resistance is common. Yet these patients may remain euglycemic because the extra fat is gone. So OGTT, if you are trying to give her a glucose load, it will trigger severe early and or late dumping syndrome, which is very common in this patient and can compromise maternal and fetal safety, including syncope, including fetal distress. And the interpretation of results is very difficult. So what do? We can do a capillary blood glucose monitoring daily before and after meals for a week at 24 to 28 weeks gestation. I told you we can't do OGTT, we can't do OGCT, so we do a capillary blood glucose. May not be the best method, but gives us some information at least, because this is a safer alternative to OGTT. An alternative could be an HbA1c, but HbA1c we know is retrospective. At least I know what is happening over the last 3 months. Congenital anomalies, they are not increased after bariatric surgery, and we already told you that neural tube defects can increase because of folate deficiency and a hyperhomocystinemia that can follow bariatric surgery. Weight gain. Do I know what is the optimal weight gain during pregnancy? Sorry, but we don't have an answer for it. Our weight gain recommendations are based only on the Institute of Medicine guidelines, which we follow for a normal pregnant patient, which depends on the pre-pregnancy BMI. So this you will have to individualize, you'll have to look for other symptoms and then try to monitor the patient. Bariatric surgery and late pregnancy complications. Reduction in all hypertensive diseases of pregnancy. Well, although earlier smaller studies showed some conflicting results. Some studies said that preeclampsia may increase, but now we know that there is no impact on the risk of preeclampsia in the post-bariatric surgery period. Preterm delivery, it lowers the frequency of preterm delivery because the medical complications associated with obesity like diabetes, like the PPROM are no longer there. But at the same time, it is an independent risk factor for preterm delivery. Bariatric surgery itself is an independent factor for preterm delivery, possibly because of malnutrition. So whatever evidence we have got over the last few years is mixed. Some will show improvement, some will not show improvement. But on the whole, the preterm delivery rate is much better than an obese patient. Birth weight. Now, there is a reduction in the birth weight because these patients have a larger proportion of AGA. We know that obese women have LGA, a large for gestational age baby. So these patients, there we have a definite benefit in getting an AGA. And why do we get the beneficial effects? It's because of what we call as BRAVE effects. What does BRAVE stand for? B for bile flow alteration, R for reduction in stomach size, A for anatomical gut rearrangement and altered flow of nutrients, B for vagal stimulation and alteration of the enteric gut microbiome, which in turn results in signaling pathways involving adipokines and GI peptides and incretins. Okay, so on the whole, AGA incidence is better than LGA incidence. But there could be a growth restriction. The growth restriction is more in a patient who has conceived very early after bariatric surgery and with malabsorptive surgery. The lesson for us, obstetricians, for us to learn is that serial ultrasound every 4 weeks for fetal growth in third trimester is mandatory. Now, an important point we need to remember is that this reduction in growth velocity is not due to placental factor, but it is related to the maternal glucose levels. So again, what is the lesson we learn as obstetricians from this particular sentence is that fetuses are symmetrically smaller with comparable HCAC ratio and normal circulatory hemodynamic parameters. That means your Doppler results are going to be normal in this FGR patient because there is no placental dysfunction. So we need to remember, we need to follow the growth, and we need not give so much importance to Doppler in this set of patients. Intrapartum and postpartum management. Similar rates of placental abruption, labor dystocia, meconium stain as in general population. So we have got a definite advantage there because placental abruption, labor dystocia are more common in obese patients. PPH, operative vaginal delivery, and third or fourth degree laceration also appears to be similar. All of you who have delivered or done cesarean section on obese patients know that PPH is quite common. Also know that if they have a vaginal delivery, the third and the fourth, first of all, you can't see what is happening there because there's so much of fat around the vulval area. So the third and the fourth degree lacerations are very common. So these complications come down. Mode of delivery, how do I deliver my patient? Cesarean delivery for obstetric indications. But please remember that these patients are going to have higher cesarean rates. Why? Because of age, and because although their weight has come down, they will still fall within the obesity range. And we know that increased age, history of infertility and obesity, the cesarean section rates are always more. So please accept the small higher cesarean section rates in this patient. Cesarean delivery technique, if it's an uncomplicated bariatric surgery, please go ahead and do a routine cesarean section. But if she has had a little complicated kind of bariatric surgery, maybe a Roux-en-Y, maybe a pancreatic diversion, then a blunt entry into the peritoneum to minimize the risk of inadvertent injury to underlying adherent bowel that could be present. So do a blunt entry so that you're safe. Postpartum, definite no increase in perinatal morbidity and mortality. So bariatric surgery is safe in that kind of a situation. Lactation is not adversely affected by bariatric surgery and should be encouraged. Micronutrient supplement and screening, however, should be continued following delivery in women who breastfeed, because this is the first time the woman can have a nutritional deficiency, as a lot of nutrients are going away in breast milk. So please continue following these patients. Now, medical and surgical complications related to bariatric surgery, which could come in pregnancy. So late post-operative complications of bariatric surgery could present for the first time. So we need to have a very high index of suspicion, non-specific abdominal symptoms, or a very similarity to pregnancy symptoms like pain abdomen, idhar dard, udhar dard, vomiting, and those kind of things. Please have a high index of suspicion and look for bariatric surgery complications like internal herniation. What we call as Peterson's herniation is very common. Gastric band erosion and slippage, anastomosing leaks and bleeding, stomal stenosis, volvulus, marginal ulceration, or a simple cholelithiasis because of the pre-obesity could present for the first time during pregnancy. So as obstetricians, we need to have a low threshold for CT. We know we are very scared of CT. We don't want to do CT. We are so worried that there is going to be high radiation. But here we have no choice. MRI may pick up only a few of these things. So CT may be required. We have a low threshold for it if there is a problem, and an early surgical intervention will be required. Dumping syndromes, I already talked about it, are very common following a gastric bypass or a sleeve gastrectomy, characterized by pain, nausea, diarrhea, flushing, palpitation, tachycardia, and maybe even hypertension. Treat it like your regular diet. Give small meals, don't give liquids, and we can use pectin or guar gum to increase the viscosity of the food so that dumping syndrome does not occur. Both these items are available to us as pharmaceuticals, as rather a nutraceutical. Mental health is very, very important. There is an increased risk of mental health problems and substance abuse. Please look out for it. Anxiety rates are very high in this patient, especially during pregnancy. Screen for mental health disorders prior and during pregnancy. Of course, none of our small town patients, but in big towns, smoking and alcohol is becoming very common among women. So smoking cessation and alcohol should be discussed with these patients. So for take-home messages, the first message is contraception. Postpone pregnancy until weight is stabilized. Avoid oral contraceptive. Give a long-term contraception. IUCD can be used. Surgical issues. Remember, we have got LAGP kind of a surgery where we can inflate the balloon, or we can dilate the stomach if we want. Weight has to be stabilized. If there is a pain abdomen, please assess. Rule out an internal herniation. Treat it promptly. Nutrients. We have discussed how vitamin D, iron, calcium, copper, thiamine, and vitamin A are important. Nutrient levels. We need to check serum indices before conception, at first visit, and at every trimester, and after giving a high dose of supplementation. Fetal monitoring, monitor growth every trimester. In the third trimester, monitor growth every 4 weeks, assess congenital anomalies, developmental problems, and intracranial bleed. If there is a vitamin K deficiency, this fetus can have intracranial bleed, so we need to monitor it. Remember, Doppler, NST, amniotic fluid volume may not give you the answers you are looking for. Diet, reduce quick absorbing carbohydrates, no fast foods, and opt for low glycemic index, avoid caffeine, avoid alcohol, give a frequent small meals. Diabetes, have a hawk's eye for it, avoid OGTT due to risk of dumping syndrome, monitor HbA1c each trimester, or put her on a continuous home glucose monitoring or a continuous instrumental monitoring or a 7-point glucose monitoring between 24 to 28 weeks to pick up GDM. Gestational weight gain as per ICM guidelines, screen for associated complications. Mental health is very important, screen for it. And breastfeeding is not compromised after surgery. Breastfeeding is recommended, but monitor micronutrients during lactation. So on the whole, we have this kind of acrobatics we need to do. Don't overnourish her, don't undernourish her. Make sure you're doing everything well, and then the woman will go home with a nice baby like this. Thank you very much for a patient hearing, and I'm here to clarify any doubts you have. Thank you.
Thank you very much, sir. It was indeed an interesting and really insightful session. I'm sure that everyone enjoyed the session. The questions which I suppose that you have already answered those questions in your slide, but maybe just for your final comments, because there might be some audience, some people who joined us a little later, so that could be the reason why they asked certain questions.
Sure,
But we can start with the first question. That is, what are the effects of bariatric surgery on PCOS? Dr. Juhi from Amravati is asking this question.
Okay. Now, we know that PCOS is associated with obesity. We know the PCOS is associated with the androgen axis. We know that fat is involved in some of the androgen metabolism. And we also know that these patients quite often are either diabetic or pre-diabetic. So once you do a bariatric surgery on this patient, there is definitely going to be an improvement of PCOS. Having said that, it does not mean that every single patient I do bariatric surgery, the PCOS is going to disappear. No, lifestyle modification, exercise, nourishment is the first answer for PCOS. But here we are talking of some PCOS who are extraordinarily obese. And you have tried IVF, you have done 3 cycles, 4 cycles. I've had patients who have undergone 8 cycles of IVF and no result. For such patients with PCOS, you may consider bariatric surgery and you will definitely have some benefits.
Surgery on fetus. Dr. Pranit is asking from Mumbai.
Yes, actually I have covered this, but number one is the nutritional deficiencies can result in nutritional deficiencies in fetus. That is why I was insisting on giving correct amount of nutrition and doing a nutritional survey, a serum nutritional estimation during every trimester. Okay, we also know that a bariatric surgery, I talked about the FGR that could come in with a bariatric surgery. I also told you about the congenital anomalies, especially the neural tube defects that could be there because of hyperhomocystinemia that could be presented because of bariatric surgery and low levels of folic acid. We also know that the incidence of diabetes will still be high in a bariatric surgery as compared to a normal patient. But this could be an advantage if you compare your patient population with an obese patient who has not undergone bariatric surgery. So there we have some kind of benefit. We also have another benefit in terms of having a normal sized baby rather than a large baby with all its attendant complications. Okay, so have said that the pregnancy has to be alone, but automatically you have to tell her that it's a high risk pregnancy. That is why I showed you that one slide with 4 important points. Patient has to be ready for it, and then only she should go in for pregnancy. Because I do not know in other places, but here we have a whole lot of population who the first question when they come to your antenatal clinic asks, "Doctor, will I have a normal delivery?" The very first visit, she just missed the period, 5 weeks, come with a positive pregnancy test. Okay, so there are this subset of population, and we need to explain to them beforehand that your chance of surgical delivery is going to be more.
So the next question is, will left band need to be removed if I become pregnant? Dr. Durga Prasad from Chennai is asking.
Will what have to be removed?
Will a lap band need to be removed if I become pregnant?
Now, generally, a lap band, unless it's causing a stenosis or unless it is causing some kind of an ulceration or causing a severe dumping syndrome kind of a picture, it need not be removed. It need not be removed because everything has got a capacity to, the stomach has got a capacity to expand, and in turn it expands the band a little bit. As I told you, now we have adjustable bands which are available, wherein the band is lying outside. So you can increase or decrease the pressure depending on what is happening. But then very few patients have still undergone that kind of a surgery. But a regular gastric band that has been put, unless it is giving some kind of, let us say, post-bariatric surgical problems, we may not have to remove.
Thank you, sir. So, next question is from Dr. Rian from Bengaluru. Can you please emphasize on contraception and pregnancy planning after bariatric surgery?
Yes, there are very two important points. One thing is the nutritional status of the patient becomes normal only after 12 to 18 months of bariatric surgery. Her weight gain also stabilizes only after 12 to 18 months of bariatric surgery. So that is why we would like to give this kind of a time before a patient is allowed to get pregnant. Now, I tell the patient don't get pregnant, but she may not understand what I am trying to tell. So a contraceptive advice also has to be given. We all know that oral contraceptives can cause an increase in weight gain. So we generally don't like to give oral contraceptives for this patient. We can give injectable progesterones, or if she already has one baby and this is before the second baby, we can use an IUCD. Although now we use IUCDs even in a nulli gravida, so that can be used. Condom, of course, always remains the best method in these patients who are planning to get pregnant in a short while. So any of these you could advise. But having said that, because I keep on getting patients who have become pregnant, they are so scared, they come to me saying, "Doctor, great, I've been waiting for a baby. I've been only 4 months post bariatric surgery, and now my bariatric surgeon had told me that for 12 to 18 months I shouldn't get pregnant. What is going to happen? Am I going to have a lot of complications?" Please reassure them. Don't allow them to get pregnant. But if by chance a pregnancy comes, I think we should support them, make them understand the complications, make them understand the extra monitoring that is required, and go ahead and let them have that kind of pregnancy.
Thank you, sir. So, sir, next question is: can bariatric surgery a necessity twice? And if yes, under which circumstances and which phase? Dr. Rahul from Haryana is asking.
Or in whom we do bariatric surgery, right?
Yeah. So, yeah, when what are the situations when bariatric surgery can be a necessity twice? So
Absolutely.
maybe two step process or twice.
Twice. Okay. Now, one thing as obstetricians, hopefully most of these women who are trying to get pregnant have been waiting for such a long time that we have the erring on the other side, that is getting too soon pregnant rather than too late pregnant. So quite often we are unlikely to see a patient, whom we require a second bariatric surgery during pregnancy. Not that it cannot happen, but we are very highly unlikely to see, and it's only once in a way that such a patient you may have. Now, having said that, there are complications that could occur during pregnancy. There could be internal herniation, there could be intussusception, there could be stenosis, the gastric gland slippage is there, gastric bleeding is there. Now, if any such thing happens, then during pregnancy we may have to undo whatever bariatric surgery, remove the band, or reduce the intussusception, and then possibly post pregnancy, if she's still putting on weight, she may require another surgery. Pre-pregnancy, those patients who are not looking forward for pregnancy, let us say a 45-year-old lady who has got a BMI of 40 is undergoing a bariatric surgery. Such patients at the end of 3, 4, 5 years sometimes do require a repeat kind of a procedure, which could be of the same time or could be of different type. But our patients are still young. As OBGYNs, I think we are a little bit lucky and we are unlikely to face this problem.
Thank you, sir. So I think one or two questions are such where, I mean, you have already answered those questions in your slide decks. For example, are prenatal vitamins good for pediatric patients? Yes, you have told us that how the higher dose of vitamins are needed and certain minerals are also needed. And
Just one point I'll make here, just
then,
one point. One point I'll make. See, the
yes,
vitamin combinations that the bariatric surgeon may have given is not the vitamin combination that we as obstetricians want. Because as I told you, retinol should not be used, calcium carbonate should not be used. So we need to change the vitamins to prenatal vitamin rather than the regular vitamins that a bariatric surgeon may be using. So if the patient comes in pre-pregnancy period or early during pregnancy, please change it accordingly.
right, sir. You mentioned very rightly that higher doses of all these vitamins are needed during the prenatal period compared to the routine supplements in
Absolutely.
non-pregnant bariatric patient. So, sir, any specific medications to be used in relation to post-bariatric surgery in pregnancy apart from these nutritional supplements?
No, I see post-bariatric surgery, especially even if their weight is not stabilized. If their weight is stabilized, all the more. But even if their weight is stabilized, they do not require anything apart from a nutritional support. Okay, as I told, some of our worries like preeclampsia, like diabetes, are definitely decreased in this population. You know, even a type 2 diabetes mellitus still remains euglycemic during pregnancy after bariatric surgery. So I would say it would act like a boon in those situations. Yes, FGR may be there. Please remember that for that FGR, do not use aspirin. We know aspirin can cause corrosion in the stomach. We don't want to use such medications. If I have a little bit of doubt about, these patients are a little elderly. Sometimes they have an autoimmune disorder. If they have this kind of a things, I would rather err on the side of using heparin early or using an HCQS if I have a little more evidence of autoimmunity than use aspirin.
Thank you very much, sir. Sir, Dr. Shivangani from Kashipur is asking that can you please summarize the dietary advices once again?
Dietary advices once again. I'll go back to the slide. We have that few minutes now.
Yes, sir. Please go ahead.
Okay, I'll go back to the slide so that it's clear. Okay, first thing is we need to know this. What is the type of bariatric surgery she has undergone? Restrictive or malabsorptive? Because a restrictive, like a gastric sleeve or a gastric band. So you need to ask that to the patient in the first visit, what kind of bariatric surgery you have undergone. And with the restrictive surgery, the nutritional management is not very difficult. It's mainly iron, folic acid, and low hemoglobin. So ultimately, because of the iron, so you need to just correct that. But with a malabsorptive kind of a procedure, Roux-en-Y, biliary diversion, then you need to remember that iron, folic acid, B12, D, calcium, hemoglobin, and even albumin, everything is going to be low, and you need to be more careful for this patient and go ahead. Now, number two is that we need to really assess how much deficiency is there. If there are any small signs or symptoms, if they are there, or the patient is vomiting away too much, she has got too much of nausea, she's not able to eat at all. In such kind of a patient, we definitely need to do a nutritional assessment of the patient. For everything, for you have to do, I've already told you ferritin, you need to do the serum iron, you need to do the vitamin B12, folic acid, calcium, vitamin D, vitamin A also you can do. Thiamine and all that, the deficiencies are not much. So if you're just supplementing, it's a water soluble vitamin. Even if I give a little extra, it's going to come out in urine. So I don't have to worry about that. Now, these special considerations are very important. I'm just repeating it. I've already told 3 times. Stomach pH is altered and surface area of absorption is decreased. Hence, preparation route or dose is very important. Now, when I say preparation, like calcium carbonate should not be used, use calcium citrate. When I say route, for vitamin B12, tablets should not be used. If they're not able to retain them, use iron injection. For iron, they may not be able to tolerate oral at all. So give her IV iron and let us finish with that. Okay. For dose, remember vitamin D requirement, calcium requirement, folic acid requirement is lower in a normal pregnant patient as compared to a bariatric surgery patient. So please err on the higher side. No harm at all. Now we are lucky in India because most of our vitamin combinations that we get are already too high. We never give 400 micrograms of folic acid. We always give 5 milligram of folic acid or 4 milligram of folic acid. So our vitamins are already loaded. So most of the time, very small changes are required in the form of molecule or in the form of IV preparation versus oral preparation. I hope that answers the question.
Right, sir. So I think, sir, most of the questions have already been covered. There were few repeat questions. So with this, I'm really grateful to you for this very exhaustive but very, very interesting. Even I enjoyed a lot being a physician that how all these things are to be taken care of, especially in the prenatal phase. So thank you very much, sir. Would also like to thank our audience who posted the questions and were really keen in this particular topic. Thank you very
And
much from
I would
Foxy
like to
and
take this opportunity to thank Dr. Alpesh that he was specially present
absolutely.
for this particular talk.
Definitely. With his blessings only, we are doing this entire series of 24 and with this third topic, which was quite interesting. Thank you
No,
very much, everyone.
he's one person who has proved what a true friend is because I know him for the last maybe 25 years. And most of our thing has been kind of a hi, hello, and on the phone or meeting in a conference. And simple, down to earth person I've not seen.
So, would like to extend my vote of thanks to Dr. Alpesh Gandhi also for his kind words and giving the overview of this topic. And thank you very much, everyone. We can go offline.
Thank you.